Going to start our tumor board session, but before we start, just want to make an announcement that this time we are showcasing this session, and we will be arranging this session once every month now as the Pakistan Neuro-Oncology Tumor Board, and we will include all the centers across the country, and they can bring their cases for this session, and then where we will have national and international experts related with the neuro-oncology, and then we will discuss their cases. So I think that we'll really look forward to this session, and then this will be an amazing opportunity for all of us to learn, and all, of course, ultimately to improve the quality of healthcare that we provide to our patients. So to start with the introductions of our panelists, we will start with, so we do have here national and international faculty again. So, and this initiative, this project will be directed by Dr. Shan Raza, who is based in MD Anderson in Texas. So today in this session, we have Dr. Shan Raza. He's a faculty member in the Department of Neurosurgery at the University of Texas, MD Anderson Cancer Center. He also currently serves as co-chair of the research committee and a director at large for North American Skull-Base Society. Dr. Michael Devon, thank you very much for joining us. Is an assistant professor of neurological surgery as well as surgical director of pediatric neuro-oncology and pediatric neurovascular program at Vanderbilt University Medical Center. Dr. Naveed Ashraf is joining us from Lahore. He has served as the professor of neurosurgery and Allama Iqbal Medical College, and currently is working at the National Hospital and Medical Center. Dr. Shayan Sirat is an assistant professor of clinical radiology here at the Khan University Hospital, and her interest mainly towards neuroimaging and oncological imaging. And we have Dr. Aisha Maiman, who is an assistant professor in Department of Pathology here at the Khan University Hospital. Dr. Asim Hafiz, he's a medical oncology, a radiation oncologist here at the Khan University Hospital, and also an assistant professor. We also have young faculty member, Dr. Adiba Zaki, who's a senior instructor and an adult neuro-oncologist. So with that introduction, and we also have in our panel, Dr. Salman Sharif. Dr. Salman Sharif is a professor of neurosurgery and head of neurosurgery at Liaquat National Hospital Medical School in Karachi. And he has been working at Liaquat National Hospital Medical College for the last 22 years. Thank you so much. And he's also the president of World Spinal Column Society. Thank you so much, Dr. Salman Sharif, for joining us today for this session. So with that, I would request the faculty members who are here, the panelists, please join us on the stage. And I think it will be better if we can have radiologists and the pathologists, if they can face the screens so that if they have to read the images or the slides, it will be easier for them. Dr. Devon, please, thank you. Join us. Yes, son. We have Dr. Adiba. Please, Dr. Aisha, welcome. And to present the first case, I would like to invite Dr. Kuratul Antarik, who's an instructor of neurosurgery here at the Khan University Hospital. Dr. Kurat, please. नहीं हम वो यहाँ पे हैं डॉक्टर शायान की सिस्टम यहाँ पे भी चाहिए रेडियोलॉजिस्ट वो तो रखा हुआ है आप अभी क्या कर रहे हैं प्रेजेंटेशन ना करना So meanwhile, our panelists are being seated. So again, just want to tell that we will be organizing these sessions once every month. And we encourage all of you who are here, whoever is involved in any kind of care for the neuro-oncologic patients. If you have any questions regarding your patients, how you want to proceed, how you want to take decisions, I think this will be a great platform for all of you to send your cases, to discuss, to learn from world-class specialists that we will be having in this, and we'll be inviting different people, different experts from the whole world. And if you also have any suggestions, please let us know. And I hope that this showcase, this session, will tell you how we are going to move forward and how amazing this project will be, hopefully. So do we have Dr. Shan Raza? Yes, we have. Okay, Dr. Naveed. Dr. Raza, can you hear me?
Yes, absolutely. Thank you for having me.
Pleasure. So we have a very good number of participants here. I hope you can see. And okay, for some technical reason, we will invite Dr. Farah Bashir first, who is a pediatric neuro-oncology fellow. And she will be presenting the first case. Dr. Naveed, can you hear us? Okay, great. And Dr. Raza, if you want to say a few words about this project that we are planning, meanwhile we are getting ready with the presentation, will be great.
Yeah, no, absolutely. I think you did a great job sort of introducing the concept of this. I think it'll be a good sort of monthly gathering, I think, where we can discuss cases from around the country and get different thoughts on managing, I think, challenging cases that we all encounter. I think the hope is also that there'll be a true sort of multidisciplinary tumor board with not only just surgeons, but also medical oncologists and radiation oncologists included as part of the discussion too. So I think this session was sort of just like kick things off and provide everybody a flavor of how things are going to look in the future.
Great, thank you. Okay, so Dr. Farah, you ready?
Yeah.
Okay, so we can start with the first case.
Assalamu alaikum and good morning. I am presenting the first pediatric case. Our patient is a 14-year-old girl, right-handed, KPS of 100. She presented with a history of blurring of vision and headache for 1 year. She had history of vertigo, severe headache, and vomiting for 15 days, and 1 episode of generalized tonic-clonic fits. Otherwise, she did not have any neurological deficit. So her initial MRI brain with contrast was done that showed an enhancing lesion along the right lateral ventricle. So Dr. Shayan will discuss the radiology.
Okay, these are T2-weighted axial images in which you can see a large inhomogeneously hyperintense lesion involving the right cerebral hemisphere, which is lying in the parieto-temporal region. It is causing significant compression of the lateral ventricles, and it is causing entrapment of the temporal horns. Here you can see some signal intensity similar to CSF. As we move on, these are the T1 weighted sequences, axial images in which we can see this is the heterogeneous lesion, which is appearing hypointense with some intrinsic T1 hyperintensity representing hemorrhage, which is making a fluid level within the temporal horn. We also see some other T1 intrinsic hyperintensity, which may represent calcification. As we move on, these are post-contrast sequences. Here you can see there is heterogeneous nodular peripheral enhancement of the lesion. It is very intense and heterogeneous with some central hemorrhage, as we've seen in T1 weighted sequences. These are the flare sequences. Here you can see there's again redemonstration of the similar lesion and its extent of an involvement.
So the next plan was to go for surgery. Her first surgery was done, and resection of the intraventricular lesion with place insertion of EVD was done. So this is the first post-op scan after first surgery.
So here we can see on T2 axial sequences, there are post-surgical changes with pneumocephalus and subdural collection along the right cerebral convexity. This is the resection cavity, as you see in the lower row on the left. And then this is the resection cavity, but we still see some T2 inhomogeneity in the similar in the tumor bed region, which and on T1, we can see again the similar area with some areas of hemorrhage within the surgical bed. And on post-contrast, these are few foci of enhancement, which are still present. Can we move this here?
Yeah.
Okay. So here you can see there's an intensely enhancing nodule and another one over here. So there's definite residual disease besides maximum severe resection. Similar findings on flare.
So
If
this is
I can ask Dr. Aisha, please. Can, oh. Just 1 minute, so mic for Dr. Aisha.
So you can see a very diverse kind of morphology. It had appearance of a low-grade glioma. On the left upper field, you can appreciate that it looks more like an astrocytoma with elongated, mildly hyperchromatic nuclei, few multinucleated giant cells, and fibrillary background. On the right upper field, you can appreciate that there's a lot of microcystic change with mucoid-filled mucinous spaces, but we don't appreciate any ganglion cells. On the left lower field, you can appreciate a lot of eosinophilic granular bodies and these glassy pink structures, which are the characteristic rosenthal fibers. And on the right side lower field, you can appreciate the classic oligodendroglial-like morphology with rounded nuclei and perinuclear halos and some chicken wire vasculature. So very overlapping features that you can collectively see in a low-grade glioma. So we had differentials of pilocytic astrocytoma and a diffuse pediatric low-grade glioma. This case was sent to the Hospital for Sick Children, Toronto, and it had this characteristic. Okay, so we don't have the molecular test over here. So the GFAP highlights the astroglial cells with fibrillary processes, and Chi-67 was slightly on the, like it was reported as like 5 to 10% in some areas. So it's a pediatric low-grade glioma, and from the Hospital of Sick Children, Toronto, the mutation confirmed was KRAS. So it was KRAS mutant. So it was reported as low-grade glioma, KRAS mutant.
So the patient remained on follow-up and
Okay, so sorry, if I can ask in between here to our panelists, if Dr. Salman Sharif would like to comment. Sir, if you get this kind of tumor in your practice, what will be your approach? And if you can give us some comments. Go back to this. Can you go back to the pre-op? Just, okay, yeah. Dr. Salman. Okay. So we can, Dr. Salman, can you, okay, yeah. Sir, so just wanted to ask, like, if you can see on your screen, if we had this patient, pediatric patient, and if you have this patient in your clinical practice, how you will approach, what will be your approach just for the young people? Yeah.
I think what has happened lately with every pediatric case, we pick up the phone. There is a contact line. There's a coordinator from our department who coordinates with the neuro-oncologist and AKU, and we share the scans. We discuss different options, and then decide accordingly. So nowadays, unlike what we used to do before, like during my training, I worked for 18 months in Birmingham Children's Hospital, and we would do whatever we wanted to do, and later on discuss in the oncology meeting, but not anymore. Everything is now done with coordination. So it's done with, we share these scans, we discuss, and then decide what exactly needs to.
Thank you. Dr. Devin, would you like to comment? Can we have mic here for the panelists? Thank you.
Yeah, thank you. We would have managed this in a very similar fashion. I think, the goals here, tissue diagnosis, tumor removal as much as possible, and reestablishment of CSF pathways. And that was certainly done. I think in discussing the next step, it'd be interesting to hear what was seen intraoperatively and understanding, say, things like the tumor plane between the tumor and the normal brain, and what was visualized and maybe not visualized in relation to the postoperative scan. But I think that would be, really important to know in surgery before kind of taking the next step. And it looks like we're about to find out what those next steps were.
Okay, great. Dr. Farah. So just wanted to make this session more interactive. So if Dr. Farah, you also have in between any question, you can ask the panelists in case if you have.
Okay. So we followed the patient, and we are going to show the scan 6 months after the surgery that showed progression of the disease.
So again, we see that there is heterogeneous signals in the tumor bed in the right trigonal region, and we can see there's significant entrapment of the temporal horn. So these are the T1 pre and post contrast sequences. Here you can see that there is a heterogeneous avid enhancement in the residual tumor, which has grown in size as we compare with the previous. And there's definite entrapment of the temporal horn. Flare sequences, again, redemonstrating similar findings.
So a second look surgery was planned after 8 months of first surgery, neuronavigation guided right-sided craniotomy with maximum safe resection of the lesion. And the histopathology was consistent with low-grade glioma, KRAS mutant. So this is the follow-up scan.
So again, on follow-up scans, we can see that this is a large resection cavity, which is communicating with the temporal horn now. And the EVT is probably not shown on these images. So these on the top row, these are pre-contrast sequences, and in the lower, these are post-contrast sequences. Here we can see that there's no definite enhancing nodule in the tumor bed anymore. So it appears to be gross total resection. We do not see any significant residual on these scans. We do see a small enhancing nodule over here, which on volume appears to be continuous with plexus. So on this scan, we do not see any definite residual.
So the patient remained on 3 monthly follow-up, and she is currently doing fine. She is not non-symptomatic, and she's a student of grade 8 and with no findings, any cranial nerve deficits or any other clinical finding. So we performed a scan on 14 months post second surgery that showed increased flare signals on the medial aspect of the resection cavity.
Okay, these are the latest scan. Again, we can see that this is a dissection cavity. And these are again, this is a similar nodule as I have shown you on the previous scan, which is seen. It is slightly conspicuous on current examination, but again, on volume sequences, it is continuous with the choroid plexus. So to me, this is not a recurrent nodule. In fact, it is a part of the choroid plexus.
So we have planned for following her up for 3 months as there is the residual nodule present. So we would like to take suggestions from the tumor board as well. So how should we proceed further with this case?
Great. So I want to opportunity to ask other panelists. So Dr. Naveed, if you're,
Yes.
yes,
Can you hear me, please?
yes, we can hear you. Thank you.
Right. Thank you very much for asking me to be on the board, and I'm really very happy to be in the company. I was also very happy to listen to Professor Salman when he said that we used to do whatever we wanted to do. And I can assure you that still in Lahore, we do whatever we want to do, despite we have a huge children's hospital over here. This particular case, obviously a very well done case. First of all, I must admit that it was very nicely excised. And superficial lesions, as we know this is a pediatric glioma. And superficial lesions can often be completely excised. But this is a one which is a deep-seated lesion and seems to be rather like an infiltrative tumor. And residual disease obviously has been historically treated with adjuvant chemo or radiotherapy. Now, currently, since we are following this patient, so the current risk stratification of these tumors, as already the genetic profiling has been done, is based on the molecular data. And since this is a KRAS sort of a tumor, probably the best option would be to use targeted therapeutics. And if our neuro-oncology colleagues are sitting over here, may I ask if targeted therapeutic in this particular case would be of help?
Okay. So we have very talented, our very own pediatric neuro-oncologist, Dr. Noring. If a mic for Dr. Noring, please. Okay, yeah, you can go. Dr. Noring, you can sit here, please. You can ask.
So thank you, Dr. Naveed, for your question. So for KRAS mutant tumor, we need MEK inhibitors. But unfortunately, we don't have MEK inhibitors here in Pakistan. And even if these are available, it's very, very costly. So for a 10-kilo kid, it's around more than 10 lakhs per month. I had the ability to get these 2 years back before COVID as a compassionate access program. But unfortunately, since COVID is here, so that thing was closed. So I'm still trying to get something available from Novartis as a compassionate access program. But till then, we can try our chemotherapy, which we are using as the first line agent, weekly vinblastine, and then maybe see if there is progression. So we can, start weekly vinblastine, and if we have the availability of MEK inhibitors, we can try later on. Because if we don't have all these facilities, and if these show some progression, so maybe the next option is radiation. But that's a very, very big field. And it's really difficult for a child who is just 13 years old to have this much radiation in low-grade gliomas.
Okay. Dr. Raza, any comments?
Well, can I ask, can I make a further observation, please?
Sorry, Dr. Naveed, you want to say something?
Yes, of course. I clearly understand that radiation therapy in pediatric patients is, of course, a problem. But can we think about any fractionated stereotactic therapy for this patient?
So thank you, Dr. Naveed, for your question. Regarding the role of stereotactic, because when we are talking about the low-grade glioma, the role of radiation therapy, particularly in the pediatric population, is not very common and very well established. So that's why it is advisable to avoid particularly the radiation therapy, particularly in the scenario when we are talking about the cross-border resection. Because when you are talking about the stereotactic radiation therapy, you need a target, as mentioned by Dr. Norin earlier, that considering the cavity and targeting all this thing with the stereotactic is a disaster. So particularly in pediatric population as well as a young population, when we have a cross total resection after low-grade glioma, there is as such no role of adjuvant radiation therapy in that scenario. Thank you.
Okay. Now I would like to ask Dr. Raza. Sorry. So yeah, what would be your approach, or if you do something different?
I agree with everything that's been said, meaning that, when there was progression, we would have taken back for surgery. It clearly is an infiltrative disease process, and with the KRAS mutation, clearly a bad actor. I think, with the progressive sort of infiltrative flare signal, certainly we'd be worried about progressive disease. And I think the next step we would look at would really be, targeted therapy given the KRAS mutation. And we definitely would hold off on radiation therapy as much as possible for all the reasons that have been outlined already.
Okay. So I would like to now ask Pakistani neurosurgeons here in the meeting, Dr. Naveed Ashraf, Dr. Salman Sharif, or if Dr. Athar or Dr. Shehzad can also give their feedback. Have you ever seen patients going for radiotherapy without histopathological diagnosis in your practice? Dr. Salman, I can start it. Yeah.
Yeah, we have seen that actually from some of the centers up north, but I haven't seen a single case like that in Karachi.
Okay, thank you. Dr. Naveed, any such encounter in your practice?
Yes. This particular question pertains to some social aspects, I would say, because since so much of stereotactic radiosurgery is being promoted and advertised on social media, that the parents, obviously these are children, the parents are often looking for something which is really non-invasive. And they just fall into the trap of radiation therapy, which is stereotactically guided. And unfortunately, I've seen quite a few patients up north, as already mentioned, and from other areas, which come to us after they have undergone radiotherapy straight away without a tissue diagnosis. And that's the most unfortunate part of it. And we need to educate the patients, the attendants about this very much.
Right, thank you. Any comment? Yes, Dr. Shehzad, please, a mic for Dr. Shehzad.
For the visitors, the background for this question is for more than a decade, Pakistan only had one center for stereotactic radiosurgery, which was privately owned and had no process for peer review. So we saw things happening, but it shouldn't have happened. But as Dr. Salman mentioned, lots of things used to happen that no longer happen. So I suppose we should just move on and talk about the future, not dwell in the past.
Thank you. Okay, so if I would like to ask Dr. Dev, any comments? Would you treat this patient at your center the same way? Would you follow up? Anything different? Anything you would like to add for this case?
I think it was well managed, and our management would be very similar to what was seen here. I think the two questions, one would be if there was any consideration after the histologic and molecular diagnosis was made in the follow-up scan, if there would be consideration for having done a second look surgery, given the low-grade histology. That being said, I think that 6-month scan demonstrates a real beautiful resection. That'd be one question. And the other, I think it's a very reasonable approach, doing a short-term follow-up scan before reaching into our back pocket with things like standard chemo or molecular therapy. So we would have done something very similar.
Okay. Thank you. So
Thank you very much.
Case, any comments, any questions from the audience? Okay, it's good. Second case now. So. Yes, sir. Any comments, sir?
Just for our guests from abroad and for those who are online, we do 12, 15 cases every week. It doesn't take this much time. So, so, so there is, quite a few people working on the computer, but we have our neuro-oncology fellow, and Asan was the fellow last year, and this year Vakas is the fellow. So it's a pretty smooth transition. So please don't judge us on this on this pause between the two cases over here. We are almost there. So I do see it on this screen though. Okay, there you go. All right, go ahead, George.
Okay, so Dr. Kurat is the instructor of neurosurgery here at Al Khan University Hospital. She will be presenting the second case. Dr. Kurat, please.
So second case is of 21-year-old right-handed gentleman presented with complaint of single episode of generalized tonic-clonic seizures.
A little bit, mic ko thoda, yes, thank you.
Okay, 21-year-old right-handed gentleman presented with complaint of single episode of generalized tonic-clonic seizures. On examination, there was no neurological deficit. So pre-op MRI was done, which showed left frontal intraaxial non-enhancing lesion. Now Dr. Shahan will come.
So these are T1 axial sequences without contrast. Here we can see, can I minimize this? Okay, here we can see there is a large area of low signal intensity involving the frontal lobe with some mass effect. These are T2 axial sequences. Here we can see heterogeneous T2 hyperintense signals, which is a large lesion occupying the left frontal lobe. It is not showing any significant surrounding edema, and it is almost reaching the midline, and it is causing some mass effect. These are T1 post-contrast sequences. We do not see any significant enhancement within the tumor bed. It looks almost similar to what we've seen on T1 unenhanced sequence. These are the FLAIR sagittal sequence. Here you can see nicely the extent of the tumor. It is the cortical and subcortical in the frontal lobe with minimal surrounding edema. Similar findings on a coronal sequence. It is almost reaching the midline and has not crossed the midline. There is some compression on the corpus callosum as well.
Okay, so yeah, can you go? Okay, so I would like to ask our panelists, starting with Dr. Salman. So if would you operate, and if you are going to operate, I mean, first question, of course, would you operate? Some questions that I will be asking will be very basic, and our panelists might feel, why are you asking these questions, and audience also, but it's purely for education of our audience and our young trainees here. So Dr. Salman, I would like to ask, would you operate? And if you are going to operate, any adjuncts will you use, or would you do it in general anesthesia, awake craniotomy? What will be your take on this patient?
I think obviously, just like any other case, every case is individualized. So depending on what the patient wants and what you want and what facilities do you have, obviously you decide accordingly. In our sense, if you have something like this, awake craniotomy is done, neuronavigation is used, and we try, if at all possible, to use monitoring. I think all those factors you can do as long as you have the facility and you're used to doing it routinely. If you're going to do it rarely, then yes, you will be causing more problems than benefit. In this particular case, the reason why I would suggest surgery is obviously the size of the lesion, the location, and we know what problems it can cause afterwards if it spreads further. So I think that may be a reason that I'd like to take it out, but I think it has to be awake, neuronavigation guided, and not any other way.
Okay. Dr. Naveed, do you think tractography has any part to play in this?
Yes, because you see, the size of the lesion is such, although it is very characteristic of a low-grade glioma, and it's in the left frontal region where obviously the motor area preservation is the prime concern. And our craniotomy obviously is going to be centered on the coronal suture, because as we can clearly see that the tumor is around that particular area and motor strip is in. But in this particular case, the fiber tracts are since a little deeply placed and we are unlikely to go to this area. This GTR obviously might be of help. What I need to add to this particular case is that my personal experience with intra-op CT in such cases has been really excellent, as the extent of tumor resection has been increased with the use, because this really provides a real-time monitoring of the excised borders, and we are able to increase the extent of resection in these cases, because in addition to the established prognosticators in these cases, that is the age, the tumor histology, and the functional status, or the molecular markers, which are obviously done later on, the extent of resection is unique in the sense that despite being an important prognosticator, it has not been completely harnessed up till now because of the very obvious surgical problems you come across while you're operating. So in the pursuit of improving the extent of resection as the technological advances of awake craniotomy and this brain mapping and DTR is the buzzword, the other in this arena is the intra-op imaging, which if available is obviously going to help a lot, and it improves the extent of resection.
Thank you. You mentioned intra-op imaging. I would like to ask Dr. Raza, what will be his surgical plan if he would use any intra-op imaging like MRI, CT, ultrasound?
Yeah, I mean, certainly looking at this case, I agree in terms of surgery being done. When I look at the T2 and flare MRI scans, I do worry a little bit about a T2 flare mismatch, and that the boundaries of the tumor may not be as distinct. Certainly in a young patient, and if this ends up being a low-grade glioma, surgery can certainly have a long-term impact. I think in terms of maximizing the goals of surgery here and the extent of resection, I would do it awake. The map out speech and the corticospinal tracts, cortical and subcortical mapping. In terms of intraoperative adjuncts, I think some of our faculty perhaps would use an intraop MRI if they were available to do it. Others, for example, would firmly just do a supratotal resection based on just mapping the motor and the speech areas, and then everything else would be resected. So I think, I agree with Awake. Just the question is about using an intraop MRI. We wouldn't use 5-ALA otherwise, and then the other adjunct to potentially use would be ultrasound.
Great. Dr. Devon, your surgical plan, if I can ask, anything that you would like to add? Do you use 5-ALA routinely in your practice?
Would not in this case. The only other preoperative adjunct that might be helpful would be a functional MRI. This is, 21-year-old, not a 51-year-old low-grade lesion. You might be pleasantly surprised if something has been rearranged, and it might give you a bit more courage going into surgery. But I agree with mapping. The other thing that I would add is I have come to be very reliant on ultrasound, specifically some of the better quality ultrasound machines that have been developed over the last few years that I almost never do a tumor without ultrasound to guide the extent of resection. Yeah, and then I suppose the very last thing would be knowing what the intraoperative specimen looks like. Of course, this looks like a low-grade lesion, but gosh, it'd be really helpful to know to exclude a high-grade lesion, knowing that you'd really want to keep the patient safe in those situations and not cause them harm if it's a higher grade, grade 3 or 4 lesion.
All right. Okay. So Dr. Kurat, please.
So this patient underwent neo-navigation guide, left frontal awake craniotomy plus maximum safe resection of region. Postoperatively, he had transient right side weakness 4+, but on follow-up, he has full KPS of 100. Dr. Shaya.
So here we can see a post-operative T1 axial sequence unenhanced, and we can see this is the resection cavity, and there is a marginal hemorrhage appearing as bright signals, and then we have some subdural collection and post-operative changes. So these are contrast sequences again. Since the tumor was did not show any enhancement on the pre-op, we do not see any significant enhancement. This is again redemonstration of hemorrhage along the resection cavity. On T2, we can see this. These are the heterogeneous signals and hemorrhage within the surgical bed. And again, the mass effect is still redemonstrated with some marginal hyperintense rim indicating hemorrhage. There is some hyperintensity along the posterior aspect of the resection cavity, which we will have a look on FLAIR sequence. These are sagittal T2 sequences again. Post-surgical changes are redemonstrated, and there's a large resection cavity with some mass effect on the corpus callosum. FLAIR coronal sequences unenhanced. Here we can see this is the subdural connection, and this is the resection cavity. We do see some abnormal T2 hyperintense signals along the inferior margin and close to the corpus callosum, and along the posterior margin as well. So this is a comparison of the pre-op tumor. This is the entire tumor, and this is the resection cavity. And we do see some signals along the margin, which may represent some residual disease.
So you can appreciate over here that it's a diffuse infiltrating glioma. You can see these elongated hyperchromatic nuclei and fibrillary background. There is no significant mitotic activity, microvascular proliferation, or necrosis. Next. So this is again on high power, showing you some of these elongated cells with astrocytic morphology and fibrillary background. Next. So these are the stains that we performed. GFAP was positive, IDH was mutant, it shows positivity. ATRX shows loss of staining in the neoplastic cells, but it is positive in the background neuronal cells and some endothelial cells. P53 shows strong positivity in the tumor cells, and proliferative index, as you can see over there on the right side of the field, you can see Chi67, it's pretty low, less than 5%. So it's consistent with diffuse astrocytoma. We don't use the word diffuse anymore. It's astrocytoma, IDH mutant grade 2.
Okay. So with that information, I would like to now ask Dr. Asim, what would be your recommendation?
So before proceeding with the recommendation regarding the role of radiation therapy, particularly in this case, we need to know about the role of radiation therapy in the low-grade glioma. The management of the role of radiation therapy or in low-grade glioma has dramatically changed over the period of time. Because traditionally, radiation therapy is a part in the treatment or management of low-grade glioma, particularly when you're talking about the tumor that is not completely resected. The patient who has more than 40 years of age, size more than 5 cm, crossing the midline. But however, over the period of time, with the development of this molecular pathology, molecular markers, we now know that the IDH mutation patient do much better as compared to the patient who don't have HTA or a wild type. So particularly in this case, the decision regarding whether to offer radiation therapy, particularly in the context of this small residual, is depend upon two things. One is the location of the tumor. because he's a young guy, only 21 years old. If you're going to give radiation therapy, then definitely you have to accept the consequences or the changes associated with radiation therapy as well. So one thing is that regarding the patient understanding about the disease itself. The second would be the compliance of the patient to the follow-up. And the third one is actually that is the most important about the location of the tumor. So if it is in a location where in case if we kept the patient on the follow-up and tumor progresses on that side and surgery would be the possible option at that particular time, then I would more incline towards offering this close follow-up rather than offering any particular treatment. But if any of the in demand of the points I mentioned earlier is actually met, then I need to discuss with the patient regarding the role of radiation therapy, particularly in this case. First, for taking all these things in context, for considering the age, this small residual, definitely the observation is the way to forward, provided the patient can fulfill all those criteria as well as our surgical colleague is also cognizant with the fact.
Thank you. Dr. Adiba. So,
So since this patient has like low-grade glioma, astrocytoma, grade 2 with IDH mutant, and neither he have any of the high-risk features like age greater than 40 or having the subtotal section, symptomatic residual disease, I would not recommend any of the chemotherapy in such patient. I would closely observe the patient and keep him on the follow-up. So even the previous data also suggests that the patient who had the low-risk, low-grade glioma, they have taken the patient closely observed versus the early treatment, which is the radiation. So there was no survival benefit was found in the patient who received the early radiation rather than there were the more toxicity. So in this situation, we don't have any high-risk feature that opted for any treatment. So I will closely observe this patient for now.
thank you. Can I ask Dr. Thompson for his opinion, if he wants to add anything regarding the
So I may be a little old fashioned, but when I looked at the sagittal image, I'm much more worried about supplementary motor and speech deficit rather than sort of, although Dr. Defoe says there's no Broca's area, I don't think it was there. So I would counsel this patient that he's likely to wake up with a deficit, could be speech or motor, but it would get better in time. And that's why I would do it asleep. I find that sometimes it's, when you're doing an awake case like this, and someone develops a deficit, which you kind of expect them to develop, it's very distressing. And it may lead you to leave some more tumor behind. So, and we would likely observe too as a beautiful resection. And so we would withhold adjuvant therapy and follow them closely as well. But I would do it asleep.
and any adjuncts you would need pre-op?
Well, I agree with Dr. Dewan. I mean, we have a very robust functional MRI setup at Vanderbilt. And, I would do that just to understand, the location of motor, but I think that would probably be the only thing that I would do differently. Yeah.
Okay, great. All right. Any questions, suggestions from the panelists, from the audience? Okay, Dr. Altaf, please.
I was just wondering that whether awake craniotomy is a hindrance to gross total resection. So how you balance, this is from neurosurgeons, how you balance this thought process that I'm going to resect the tumor completely versus I'm going to leave the tumor and rest for the radiation oncologist and medical oncologist. Oftentimes we get frustrated when patients develop the weakness or some speech problem, and most of the time they improve. So how to balance this precarious kind of thing in your mind?
So you're asking this question from neurosurgeon. So yes.
I don't have an answer. I think if any of us did, I mean, of course, that's the challenge, right? That's what makes these so difficult. But it kind of goes back to some basics, I think, in medicine and talking to the patients, and when they're kids, talking to their parents and having them understand the risks and the pros and the cons I think that's a hugely important part of, of this work. I'm not sure I have a better answer than that.
Okay. No, that
I
makes
think
sense. Dr. Raza,
adding to that, I think just within the context of this, right, it really depends on the diagnosis. So putting that question in the context of the residual here, right? So, if you were to say that the residual flare signal disease there was left behind because of positive mapping during the awake craniotomy, then, what can happen over time with that residual is just this plasticity and reorganization around that. And so when you go back for a reoperation down the road, let's say when there's progression, then often those risks of deficit go down. So I think you have to weigh that risk of incurring a deficit versus the diagnosis that you're dealing with, right? Versus if you're dealing with, for example, high-grade glioma or glioblastoma, whether you incur that deficit, and that impact on survival, that's a very sort of tailored decision to the family and what they're willing to take on. With a low grade, you can sort of hopefully count on plasticity sort of working in the patient's favor and bring that patient back for completion operation down the road once they're reorganized, hopefully.
okay, Dr. Shazad, no? Okay. Dr. Raza, can I ask one more question? That's so you're working in Texas, you must have patients who are bilingual, if not multilingual, doing awake monitoring. Do you have any experience or any protocol or something, which language you are going to sacrifice if it's then Leon is involving the broadcast, whether it's Spanish, the first language being Spanish or English? Have you figured out something or have you faced such situation in your practice?
So I mean, those language sites can certainly be different depending on what language you're testing. So we do test, for a bilingual patient, we'll test both languages. And of course, their primary language that they're relying on, we will, we'll do everything to preserve that. Ideally, preserve everything. But if you have to pick one as their primary language, then we'll do everything to preserve.
Right. All right. Comments? Okay, we have one question back here.
Can I just budge
Yes,
into
sir.
the comment? Yes,
Please,
yes.
please, Dr. Nagin.
First of all, I would definitely like to agree with this suggestion. I feel much more comfortable doing this patient in general anesthesia. And as far as the question regarding the extent of resection, my answer to that would be that my instincts would guide me when to stop.
Great answer, sir. I think that you're talking from your experience. So we have to rely, right? I think at our levels, we are relying on your experience, experts' experiences, and the technology. Okay, we have another question there, yeah.
Hello, everybody. I'm Vasil, fourth year MBBS student from Ziauddin Medical College. Firstly, it's an honor to being here and listening to all of you, such noble persons and personalities. So my question was like, at my level, my question is that it might be a bit not so great, but the question that I have actually encountered in my boards and rotations, that the patients basically and their attendants, the main question is about survival prediction. So you being in this field, have you had come across to this question a lot, that the patients and their families do ask that how much time do we have and what will happen in the future? So based on your experience, on what basis do you predict the value of survival prediction? Is there any statistical basis? Is there just the random experience that you have over the years? So that's my question. Thank you.
Thanks for the question. Anyone wants to take that question from our panelists? Dr. Athar, you want to comment on? Sure. A mic for Dr. Athar.
Thank you. So yeah, that's a very important question, and that talks about that as a medical student, you're looking at the whole patient as a person. And as you become a neurosurgeon, you start to look at only brain and you forget the patient. And then when you become a neuro-oncologist, you only look at the tumor and you forget the brain. So keep that alive in you, that you are treating a patient, not a tumor. Yes, there are statistical data available. And when you see the patient first time, you don't know exactly what the histopathology is. You don't want to scare the patient away and make them hopeless at the very beginning. So there has to be a very fine line of giving them hope and also getting them prepared that what's coming ahead. And that's where when Professor Naveed Ashraf says instinct. So you develop your instinct over time that how much to say at that point. And usually what I tell them that, if it looks like a bad tumor, I give them some indication that it's a bad tumor, like it's a GBM. Otherwise, you give them more hope than that, this does not look like a cancer. We will get the histopathology and then let you know. Once the histopathology comes out and you have taken the case through the tumor board, then you yourself feel more confident about the overall prognosis and survival. And then you have to sit down with the patient and tell them about the prognosis in more detail and what they are going to go through after this surgery, because in many cases they are going to go through an adjuvant therapy as well, and you prepare it for them. But the most important thing when you tell them is when you tell them all about this is not to lose the human touch, not to lose the touch of some hope that you want to give them, but at the same time don't let them run after a false hope. So that comes with time, I'm sure. Some people are very good in that, and I've seen some very old persons like me also not able to do that in a very good way. As long as you keep that alive, that's good.
I think, thank you very much. So if there is 90% chances of having good resection, you first tell that to the patient rather than saying 10% chances of infection and you being dead. So, and like Dr. said, you learn that with your experience. So, okay. So with that, we end the second case. Now we have the last case, the third case that I would invite Dr. Ahmer, who's a neurosurgery resident here at the Aachen University Hospital.
Hello, everyone. So the next case is 18-year-old right-handed boy. He presented to us with blurring of vision for 3 months. On examination, he had bilateral finger counting. However, the rest of examination was unremarkable. The preoperative MRI showed a large solid and cystic cellular and supracellular lesion with extension into the nasal cavity and paranasal sinuses.
So again, the same thing, it does not take that long, usually like Dr. Athar said. So, okay. So can we start, Emmer? From the first slide in. Yeah, thank you.
So this is a case of 18-year-old right-handed boy. He presented to us with blurring of vision for 3 months. On examination, he had bilateral finger counting. The rest of the examination was unremarkable. On preoperative MRI, he had a large solid and cystic cellular supracellular lesion with extension into the nose and paranasal sinuses.
Okay, so these are multi-sequential images in which the first row is pre-contrast T1, then there's T2, then we have post-contrast T1, and then we have flare. So on the first sequence, we see some low intensity signals within the paranasal sinuses as well as the nasal cavity, and it is involving the cella and the paracellular region. On T2, it is appearing heterogeneously hyperintense with some mixed signals. And on post-contrast, it is showing significant post-contrast enhancement. And on flare, the lesion is redemonstrated. So again, these are pre-op images in which we have the similar sequence. The T1, it is showing a large cystic cavity, which is in the supracellular region, causing significant mass effect and compression of the adjacent brain parenchyma. And here we can see nicely the optic tract and the mammillary bodies, the hypothalamus. And on post contrast, it is showing a smooth marginal enhancement with some enhancing nodule. The lesion again redemonstrated on FLAIR, which is showing mild suppression of the cystic signals, and the lesion appears hypointense, the solid one. So moving on, this is pre-op contrast coronals. And here you can see the extent of the tumor. It is nodular. It has nodular solid component, which is predominantly extending into the paranasal sinuses and the nasal cavity, with intracranial as well as sinonasal extension.
So I would like to ask Dr. Raza, if you can comment on this case, what will be your surgical approach, your plan for this lesion particularly?
Sure. Can I ask what the patient's pituitary gland function was like?
Sorry, sir?
The patient's pituitary gland function, was that evaluated?
The pituitary functions were all unremarkable. They were normal.
I mean, certainly when I look at the diagnosis here, craniopharyngioma certainly comes to mind. This mixed solid cystic lesion, involving the cell of supracellular space. In terms of other diagnoses, I really wouldn't think of any sort of sinonasal malignancies that would have this appearance. So, in terms of treatment here, I would start out with surgery. The goal of surgery really is a gross total resection. Ideally to resect all the solid disease and ideally all the cyst. Sometimes the cyst wall can be extremely adherent to the vessels and the optic apparatus. And in terms of surgical approaches here, I personally would do an expanded endonasal approach. But there are other ways to tackle this, like a combined transcranial, transfacial approach as was done.
Okay, so you'll go endonasal. Dr. Salman,
I think I agree with Shan that, if I was going to approach this, if once you decide, then there are two ways. I'll first discuss with the family and give them the two options. One is, as Shan said, to remove it completely, or in first stage, just do a biopsy and then decide exactly what you're going to do. Obviously, if you think it's cranial, then it should be removed completely if at all possible. And I think endonasal approach would be the right way to go here. I totally agree.
Okay. Dr. Naveed, your comment?
Well, looking at the size of the tumor and its invasion into the sinonasal area, my preference would only be a bifrontal transbasal approach, where I would be removing the orbital rims and the bridge and gain access to the tumor 360 degrees. And I can also gain access to the sinonasal area with this particular approach.
Okay. Dr. Dewan.
I agree with the notion of getting a biopsy first. It certainly, as Dr. Raza mentioned, has a lot of features consistent with craniopharyngioma, but there is a differential here. And so I think that would be very important to know. If it indeed was a cranio, I agree with the endonasal approach. This is a post-pubertal individual, so I think that would further support a gross total, and again, via endonasal, I think would be the best option here.
Okay. Dr. Noreen, if I can ask you a question. If you have this patient in your clinic, will you send to the surgeon?
So to be very honest, so if you send this patient to my clinic, on the basis of radiology, my first differential is cranial. The other one is of course, pilocytic astrocytoma. But, and then I have to discuss it with my radiologist if she also thinks that it's a craniopharyngioma. So I would recommend to have safe surgical resection. But before that, I'll always recommend to do a eye assessment and an endocrine evaluation. So we did that, and the eye evaluation was pretty bad. And I think he lost already one eye vision. And although the pituitary hormones all were normal.
Okay.
So he underwent safe surgical resection. And then we followed him up for quite a long time. So, so for children, so he is 19-year-old, but as we are seeing more cranios as compared to our adult colleagues. So, and in Pakistan, it's really difficult to, kind of develop these kind of multidisciplinary approaches. So we always recommend to have an MDT pre and post treatment, and then, follow these with the help of endocrinologists, ourselves, surgeons, and radiation oncologists.
Right. Okay.
So more quality of life, so better quality of life than, exuberant surgical approaches and radiation.
Okay.
For children.
Okay. Thank. Okay, Amar, yes.
So he underwent neuronavigation guided by frontal craniotomy and lateral rhinotomy along with maximum safe resection of the lesion.
So you can appreciate over here, the quality is not that good. Sorry. You can appreciate the anastomotic islands and cords of well-differentiated squamous epithelial cells loosely arranged in the center, forming stellate reticulum and showing peripheral palisaded layer of tall columnar cells. So this is a classic appearance of craniopharyngioma, adamantinomatous type. Next. Here you can see a lot of cystic degeneration with a lot, the dark blotches are all dystrophic calcifications, and in the lower part of you can see glassy pink anucleated material. This is all wet keratin. So this is again classic components that you see in a craniopharyngioma, which is a WHO grade 1.
So the histopathology came out to be adamantinomatous craniopharyngioma WHO grade 1. Post-op MRI.
All right, so these are immediate post-op. All right, so these are the pre-contrast in the first row, then we have T2, and then we have post-contrast. And on T1, we see some soft tissue within the paranasal sinuses and the nasal cavity, as well as in the sella, which is still persistent. And it is returning heterogeneous signals on T2, and on post-contrast, we see there is some enhancement of the soft tissue, which is locally infiltrative. All right, in the intracranial portion, we see that there is again redemonstration of the cystic lesion, which is almost unchanged in size, and it is showing again a smooth rim enhancement with some enhancing nodular component. Similar finding on a coronal T1 post-contrast sequence, we can see the extent of the tumor. It is extending in within the paranasal sinuses with some expansion and in the cellar and suprasellar region. However, we do not see any obstructive hydrocephalus. In this saddle sequence, we can appreciate the extent of the tumor. It is predominantly within the anterior cranial fossa, and we see that we do appreciate the optic chiasma over here, which is not very well shown because it is more nicely seen on a T2 weight sequence. But we can see the extent of the tumor. In the middle image, you can see that this is the entire tumor, the soft tissue component and the cystic component.
Okay.
So follow-up MRI was done 1 year later after the first initial surgery. It showed.
Okay, similar sequences. We can, again, there's redemonstration of the lesion, which is showing enhancement with similar extent. Now here we can see that there's a slight increase in the size of the solid enhancing component, and there's slight increase in the surrounding vasogenic edema with some mass effect. So subjectively, this is it has increased in size. And on a sagittal sequence, we can see that there's again a redemonstration of the lesion. The cystic component appears to have increased in size, and similarly, the solid component also shows extension posteriorly into the sphenoid sinus, which was not seen initially.
So he underwent redo bifrontal craniotomy, lateral ionotomy, and resection of the lesion, along with removal of the ethmoid bony apparatus floor of the sphenoid and right maxillectomy. So a follow-up scan was done 1.5 years from the initial surgery, which showed some residual disease.
So now we can see that there are some post-surgical changes on a T2-weighted sequence in inferior frontal lobe bilaterally. And again, there is some soft tissue on a T1, which is showing significant post-contrast enhancement in this region. Again, we can see there's some enhancing soft tissue within the paranasal sinuses, as well as within the sella, which suprasellar region, which appears expanded. Um, and however, it is not showing that significant enhancement. The infundibular stalk is seen nicely over here. It is showing enhancement. So here again, we can see some post-surgical changes within the paranasal sinuses, as well as admixed post-contrast enhancement suggestive of residual tumor, which is also seen within the sella, as well as showing some extension into the right cavernous sinus.
Okay. Edmund, can we go a little bit faster in the presentation so that we can have some more time for the discussion, have limited time?
So a follow-up scan was done 2 years from the initial surgery, which showed stable disease. So this is the comparison of last 2 scans. So currently the patient is blind from one eye. However, he is able to read from the other eye, and he has started his normal routine and working.
Is this the last scan of this? So Dr. Shayan, if you can comment on this, please.
So these are the coronal flare sequences. Here we can see this is the image taken at the level of sella. And here the optic chiasma is nicely shown, and this is the pituitary gland. And in the last image on the right, we can see this is the midline stalk and the chiasma and the pituitary gland, which is well preserved. We see some post-surgical changes within the paranasal sinuses. Okay. So these are the images.
Okay. So I would like to take input from radiation oncology. What will be your recommendation, sir, in this patient?
So the role of radiation therapy, particularly in the craniopharyngioma, depends upon different things. One is that if there is a cross-border resection, then I don't think so there is. Okay, sorry. So if there is a cross-border resection or there is no residual as such, I don't think so there is any role of radiation therapy in particular types of glioma. However, cases in which there is extension into the paracellal region, particularly in the paranasal and also in the paranasal sinuses and nasal cavity. So in that particular situation, radiation can be considered because to provide the local control. Though this patient has already had this visual problem and has lost one vision from the one eye, but still because if it progresses, then definitely it will lead to the other problem as well, like headache and then the pituitary function as well. So looking at the scan, particularly in this context, yes, there is a role of radiation therapy is there. Though this patient is stable on the subsequent follow-up MRI, but looking at the extent of the tumor, particularly in this case, I think the radiation therapy can provide a bit more local control.
Okay. And radiotherapy conventional, or you will go for the stereotactic one?
So when we're talking about the stereotactic radiation therapy, so there's one thing, stereotactic therapy for the understanding of the general population is more conformer. But when we are talking about the stereotactic radiation therapy in less number of fraction, then the doses per fraction would be very high. So the important consideration in that particular situation is that the surrounding structure like operating apparatus and the pituitary gland, all these things need to be has a distance from the primary tumor. Ideal situation, particularly for cholangioma, if there is a close relationship with the tumor of operating apparatus, it is recommended that you can consider stereotactic fractionated radiation therapy rather than pure stereotactic radiation therapy. The other way around is the VMAT base or the conformal radiation therapy as well. It can be approached, but particularly when we're talking about the stereotactic radiation therapy in the craniopharyngioma, that point need to be considered before proceeding with the stereotactic.
Okay. Dr. Adiba, do you have any input for this case?
So in craniopharyngioma, there is no systemic therapy have been approved. The primary treatment is the surgery and if there's residual radiation therapy. But now the more molecular data, there is some role of the BRAF inhibitors, the patient who have BRAF V600 mutation positive. So there is a combination of BRAF and MEK inhibitor that shows some responsive disease.
Okay. Dr. Noreen, anything that you want from your surgeons?
Safe surgical resection. And prevent complication, prevent vision, prevent hypothalamic pituitary axis disease, and again, a multidisciplinary team approach.
Okay.
So what I would recommend in this, the reason of doing the BRAF, although it was a adamantinomatous craniopharyngioma, and BRAF is not usually associated with that type. It's more common with the papillary type. But initially, we were very much thinking that maybe if he underwent surgery at that time, he may have significant complications. So that's the reason we have done this. We have asked Cynthia to done this test, and it was negative. So, and when it progressed, then at this point, we have planned and we have asked you to have the surgical resection. But even at this point in time, he has a small residual disease. He's perfectly well. He's doing fine. So I would recommend to continue follow-ups rather than go for a radiation at this point in time. But the key here is the follow-up, regular follow-up.
With the MRI, 3 months, 6 months, 1 year, what you 3 months. Okay. Okay. Dr. Demo, anything you would like to add in this case?
No, I think the only other I deal with the pediatric side, and so I think some of the major differences in terms of management in these particular patients is the degree to which the cranio is cystic versus solid, and the age of the patient and whether they are not prepubescent. And so, for example, in a cranio that is primarily cystic or all cystic in a prepubescent child, in a patient like that, we'll actually place an Omaya in the cyst and send them for radiation, get them through puberty. And I know there's a lot of centers that are now kind of moving towards that philosophy in younger children.
Okay.
I wonder if that's done here.
Yeah. So, okay. So we have approached our time limit, but I would like to ask one final comment from each of our experts on Zoom. Dr. Navi, do you think, so Dr. Devan just mentioned about Omaya. What are your thoughts about that?
That is an option. Cystic cavity radiation has always been an option. And previously it was not very commonly used, but now many people are employing it, especially the pediatric neurosurgeons. They are very much in favor of it. But I would definitely like to comment on this particular case that it is really very well done, because I have a very special interest in it. And the Axial has been excellent in terms of what the size of the tumor was and how it was extending into different cavities. And my recommendation would be that we keep on following this patient at 6 monthly intervals with MRI.
All right, thank you. Dr. Salman, anything you'd like to add?
Well, I think I agree what's been said, totally agree. I think it is well done. And eventually the results are good. So as long as they're always good, you don't need to do anything at the moment.
All right. Dr. Raza, your comment and also your concluding remarks and a few words regarding this project that we are planning, Pakistan Neuro-Oncology Tumor Board on monthly basis, please, sir.
Yeah, it's, regarding the case, it was really well done. Just a couple of tips from the surgical standpoint. So, certainly in terms of where the residual disease is located, it's right along the upper aspect of the ethmoid sinuses, along the cribriform plate and the fovea ethmoidalis. And, if you're going to do a bifrontal craniotomy to get that area, basically that's sort of a blind spot. And in order to completely remove that, because if that disease progresses, I would offer repeat surgery. And you could redo the bifrontal craniotomy, but some key tips there in terms of getting all that out is one, to bring the bifrontal craniotomy down low to the nasofrontal suture so that you're directly tangential to the paranasal sinuses. And then the other thing is actually completely resect the cribriform plate and the fovea ethmoidalis. So take all the bone from orbit to orbit, frontal sinus all the way back to planum. So you have direct access to the paranasal sinuses, and you're really looking at the optic canals at the end also. And that way you really could get a gross total resection of everything that's there and hopefully spare the patient radiation therapy. So certainly, while I said I would have done an endonasal approach before, if you are going to do a bifrontal or transbasal approach, that area is hard to get to via lateral rhinotomy. And so you really have to rely on the bifrontal transbasal approach to really maximize that access, and you can really get all that out if he recurs. Otherwise, just in terms of comments of the session, this was a great session, and we hope to sort of structure future sessions this way in terms of 2 to 3 cases per session and really a multidisciplinary format. And we're hoping that participants basically submit cases that they generally want a second opinion on, and it's more than just a show and tell. So looking forward to future sessions.
Thank you so much. So we can just take one quick question from Dr. Altaf, and then we will conclude the session.
Thank you, Hassan, giving me time for at last moment. So my question was directed towards neurosurgeon and specifically skull-based neurosurgeon, Dr. Shan Raza. I would like to quote a neurosurgeon, a senior neurosurgeon, I think it's a Dandy or Cushing, that no disease is so much baffling and challenging than craniopharyngioma for a neurosurgeon. And it stands true for today as well. So when we resect the tumor, we always, as a neurosurgeon, try to follow the course of tumor. But oftentimes, the most difficult part is having the stalk, A, B, the perforator going into the hypothalamus. And post-operative, these two things, if we damage them, they give tough time to the patient and to the neurosurgeons. How to balance this thing? How to resect the tumor without giving any hypothalamic dysfunction, as well as diabetes insipidus?
Yeah, I agree. I think there are very few surgeons that claim to be craniopharyngioma experts because of all those reasons that you highlighted. I guess, for me, I've just learned to tailor the expectations of surgery to the anatomy of the tumor and the patient. So, anatomically, the way I think about these tumors, you have the pre-infundibular craniopharyngiomas, the transinfundibular, and then the retroinfundibular craniopharyngiomas. And they certainly all arise from the stalk. But the pre-infundibular craniopharyngiomas, when you look at the MRI scan, you can typically see the stalk. And most of the solid tumor is basically subchiasmatic and in front of the infundibulum. And in those patients, certainly after you initially debulk the tumor and preserve that arachnoidal plane and the perforators around it, you ultimately can identify the stalk and make an elective decision about what to do with the stalk. The retroinfundibular craniopharyngiomas, again, have attachment to the stalk, but most of the mass is in the interpeduncular cistern. And those patients often present with normal pituitary gland function preoperatively. And while you could perhaps get a gross total resection, they're at high risk for incurring a pituitary deficit because of the amount of manipulation that's needed with the gland. And then you have the transinfundibular craniopharyngiomas that I think are the highest risk for poor outcomes. And these are the patients who preoperatively will have some cognitive deficits, some pituitary deficits. And then when you look at the MRI scan, the entire infundibulum is just thickened, and there's probably some mass extending into the third ventricle. And then in those patients, I always look at the T2 flare, and you can always find some flare signal change in the hypothalamus. That patient population, I think, is the hardest, surgically speaking, because in order to get any sort of meaningful resection, you're essentially sacrificing the stalk. And, no matter what, their outcomes are really poor. I think to the point about preserving the perforators, there's always a thin layer of arachnoid around these tumors when you look at them either transcranial or endoscopically. And to preserve these superior hypophyseals, I think, is key. There's always a few going to the tumor that you selectively take, but going to the optic apparatus you preserve. And then in terms of the playing against the hypothalamus, that's really an intraoperative decision in terms of after you've debulked that tumor, whether or not the capsule just falls away from the hypothalamus. And again, preoperatively, the patients with cognitive deficits and T2 flare signal change in the hypothalamus are the ones where usually when I go and I know that there's not going to be a good plane, and those are the patients where perhaps you might electively leave some tumor behind to preserve that cognitive function.
Okay, thank you so much. So with that answer, we are concluding our this tumor board session now. And if you have any other questions, comments, panelists will be outside for the tea, and you can ask the questions during the tea. And thank you so much, all the panelists and the presenters and all the panelists who joined us virtually at Zoom. And we really look forward to these sessions in coming months. Thank you so much. Thank you.
Thank you.